introduce you enough, because just having 2 minutes will not be fair to introduce you, but I will give your major role. And Dr. Erin is a family physician. She have done multiple different specialities. She have done on anthropology initially. Later she have shifted in medical science, and now she is a family and physician. She is an professor. She's assistant and clinical professor of medicine in Columbia University. And Columbia University, we all knows it's in New York and USA. Dr. Erin was also in Somaliland in 2001 and 2002. She had been serving for the Somalis for that 2 years. She have familiar with the Somali and culture and Somali family. So we are really glad having her given us this wonderful and topic, the role of families and caregivers in mental well-being, which is really the kind of area which Somalis nowadays need. Because if you have a crisis in family, then you will have a crisis in the whole society, because the basic unit of any society and the nuclear of any society is the family. So let me hand over to her and not take too much time. Thank you very much, Dr. Erin. For I might mispronounce your name, so sorry for that. So welcome, Doctor.
Well, thank you very much for that introduction. I'm very humbled by it. And let me say it's an honor and privilege to be with all of you today. So thank you very much, Dr. Daoud, for this invitation. And as you mentioned, yes, I did spend some time in Hargeisa very early in my career, 2 years. And it was quite a formative 2 years in my early training. And as I had shared with him, it actually, that period in my life is what prompted me to go back to school. I was an anthropologist at the time, and it is what gave me the courage to go back to school and study medicine. So I hold a very special place in my heart and my mind for Hargeisa, Somaliland, the Somali culture, the Somali people. So thank you for allowing me to be here today. And I will be talking with you, not to you, with you, about the role of families and caregivers in mental wellness. So let us start our journey on this very important topic. Just setting out what I want to share with you today, a few of the learning objectives. So the first will be on what is understanding the impact of families and caregivers on mental wellness or mental well-being. We can use those terms interchangeably. And then exploring the effective strategies for collaboration, identifying what may be some challenges, but also solutions in engaging caregivers. And then we'll look at some real life examples. I've got 3 different case studies that we can explore what engaging families and caregivers looks like in the real world. So we just won't talk about the abstract. We'll look at what does this look like in real world examples. Before we jump in, I think it's really important that we always have a shared understanding of definitions, right? So when I use the term family and caregiver, what am I actually talking about? Let's start with family. So people may have all different understandings of family. When I'm using the term family, what I mean by that is those with a significant personal relationship. So it could be those that have a biological relationship, right? A mother and a father and their children. It could be partners, a husband and a wife. It could be ex-partners, an ex-wife, an ex-husband. It could be people who are just living together. It could be other people who play a significant role in each other's lives who may not have that kinship relationship. When I use the word caregiver, that means someone who is actively supporting or assisting or providing unpaid care. And that unpaid part's really important. So it's not someone from the outside who is paid to come in and provide the support or the assistance. It's someone who is providing it without being paid. And usually, this is someone inside the family, right? So you see in blue, I wrote that these roles often overlap. So someone in the family is often the caregiver. And importantly, these roles often evolve over time. Okay, so hopefully we have a shared understanding of these definitions. So why are these roles important? Well, families and caregivers often provide critical support to people living with mental illness, and they can influence treatment outcomes and the recovery journey. There are many studies, and I'll talk about this in a little more detail later in my presentation, but there's a lot of evidence that reveals that patients with mental illness have less frequent relapses and fewer hospitalizations when they have families that more actively participate in their care, right? So they have better outcomes overall when the families are more involved. And importantly, health professionals, and I know that many of you on this call today, listening to this presentation, are health professionals. So maybe we've got some doctors or nurses or psychologists or social workers. So health professionals play an important role in engaging the family and helping to guide this support. I want to pause for a second and talk about a really important movement, which has been called the deinstitutionalization movement, and the role that this has played in family engagement in mental health. So, deinstitutionalization, which means the shift of services, of mental health services, from inpatient care, inpatient hospitals, to care in the community, this shift in focus of support from the hospitals to the community has meant that families and caregivers are playing an even more important role in supporting mental wellness. So, as we are seeing globally this increasing trend in deinstitutionalization and a lot of advocacy work supporting deinstitutionalization, the need for families and caregivers to become more involved and more engaged in the care and support of people living with mental health needs is going to be important. And that's what that image on the left shows. So let's talk about the types of support that families and caregivers provide, right? Because they do so many critical things. So the first area is around what I call emotional support. So things like being present, listening, offering encouragement. The next area is around practical or logistical support. So if you pause and you think about all the things that could fall under that category, right? And there are a lot. I've just listed a few examples. Things like helping with the transportation, right? Getting to and from appointments, helping with medication reminders, for some patients who have severe mental illness, helping with basic daily care. And then there's another category around financial support. So covering the treatment costs. In some places, unfortunately, there are high out-of-pocket costs for coverage of mental health services, or the financial costs associated with housing. This, for many individuals, will fall under the types of support that families provide for patients living with mental health needs. And then the last area is around advocacy. This could be support for navigating the health system. It can be very complicated in a fragmented health system, figuring out where to get the right kind of services. Or this could be speaking up for the patient, right? If the patient isn't receiving the right kind of care, patient-centered care, or the patient you feel is not being cared for in the most appropriate way. Or this could be community advocacy. And you'll see in one of the case studies, I bring advocacy to light. So there are many very important ways that family and caregivers provide really critical support. I thought it was important to reflect upon, how does culture influence family engagement? And this is always an interesting and sometimes tricky area to navigate. Um, I've divided it into 5 different areas. And as I am touching upon these 5 areas, I want you to reflect upon a really important question for your own sphere of practice, maybe your own lived experience. And that question is, how does Somali culture influence family engagement? Okay. That question again is, how does Somali culture influence family engagement? So when we think about culture more broadly, how does it influence how we see mental health? So mental illness can carry stigma and shame, and this can make it hard for some families to talk about it. Some cultures may see mental illness or mental distress as a spiritual issue, maybe a test or a punishment, and this can influence how and where help is sought. How does culture influence how we communicate as families? Different cultures may have different ways of expressing emotions. So some families may be very open in the way that they talk to each other. Some Families being influenced by culture may be more reserved and they don't communicate openly. In some cultures, it may be the family elders or the leaders who are making the health decisions, and that can limit individual choice. How does culture influence how we seek help? So some families may prefer to turning to relatives or religious leaders or community members rather than seeking care within the formal health system, right? Rather than going to doctors or therapists or social workers. And in that same vein, they may have had past negative experiences with the health system and therefore have a deep mistrust. And it can discourage families from seeking formal help within the health system. How does culture influence the role of the family? So in some cultures, it might be the entire family that will share the responsibility for the loved one's mental health. In some cultures, their belief system, they have strong beliefs about who should actually be the one who is giving the care. So that caregiver. And often it's the woman, right? It's the role of the mother or the grandmother. And that can affect how the actual support is provided and the division of roles and responsibilities in the family. And then lastly, how does culture influence how we cope? And I'll talk a little bit about this later in the presentation when we talk about stresses related to caregivers. But culture can influence how families um, have their coping mechanisms. Families will often use traditional ways of coping, like prayer or herbal medicine or certain traditional rituals, which may or may not match the medical advice of doctors or therapists. But blending cultural practices with professional care can improve support and healing. So as I was going over those 5 areas of cultural influence, I hope you were reflecting on the specifics of Somali culture and thinking about in your scope of influence professionally and personally, how Somali culture can influence those areas. Now I want to present the first case study. And this is a story about Musa and Awa, and it comes from Bamako, Mali, so West Africa. And I didn't dare tell any stories about Somaliland or Puntland or Somalia. I wasn't going to tell stories to you about your own countries. So I've used stories from other parts of the continent, but I think you'll be able to draw some interesting similarities. You'll see these are long stories, but I want you to just sit back and listen as I tell this tale. I've also written the tale down, the story down, so you can follow as I tell the story. Okay? So Musa is a 30-year-old man living in Bamako, Mali, where he works as a motorcycle mechanic. He lives in a multi-generational household with his wife, Awa, their 2 children, and his elderly parents. Over the past year, Musa began showing signs of distress following the unexpected death of his close friend, mounting financial stress, and work-related burnout. Symptoms included chronic fatigue, emotional withdrawal, poor sleep, loss of appetite, and low motivation. Musa initially thought his condition was because of spiritual imbalance and personal weakness. He tried to manage it with his own through prayer, herbal teas, and isolation. It was his wife who noticed the changes most clearly, including his withdrawal from his children and his loss of interest in his work. She persuaded him to speak with the local community health worker. After a brief screening using culturally adapted tools, Musa was referred to the community health center. There, the nurse conducted a more thorough screening and discussed potential diagnoses like depression and adjustment disorder. Due to the moderate severity of his symptoms, Musa was referred to a psychiatric nurse based at the district referral hospital. The psychiatric nurse conducted a detailed evaluation, confirmed a diagnosis of moderate depression, and provided Musa with psychoeducation, explaining how emotional stress can affect the body and mind. Musa was reassured that this was a common and treatable condition, not a spiritual failure nor a sign of weakness. Musa was offered a combination of non-medication-based counseling, cognitive behavioral therapy, also called CBT, and a short Musa's family, so here's where we talk about the family engagement. Musa's family was also engaged in his care in two important ways. So the first was through family counseling sessions. The nurse invited Awa, where they discussed how to support his recovery, avoid blame, and reduce. The second way, cultural integration. Musa's family continued their parallel support with a trusted traditional healer who offered herbal treatments and prayers. The clinic respected this parallel care as long as it did not conflict with the medical treatment plan. After 4 months of integrated care, Musa showed significant improvement. He regained interest in his work, reconnected emotionally with his children, and began taking part in community activities again. He continues monthly check-ins at the community health center and has gradually tapered his medication with supervision. His family reported deeper understanding of mental health, and Awa has become a vocal advocate for women supporting their husbands through psychological hardship. Musa now occasionally speaks at community health forums, encouraging other men to seek help without shame. So that's the first case study, and I think it highlights really nicely ways that the family can be involved. So you see elements of this emotional support, and you see elements of incorporating the cultural integration, and in the last bit of the advocacy role that families can play. I want to talk now about the benefits of family engagement. I mentioned briefly at the beginning that there is a lot of evidence showing that engaging the family can have positive outcomes. Here, I present that evidence and what it actually means in terms of the strong outcomes. So we know when we have families involved in supporting patients, we have better quality of life experienced by people with mental health conditions. We have reduced social impairment. There's improved access to mental health service during times of crisis. There are improved outcomes, fewer relapses, longer duration between relapses, shorter hospital admissions, shorter inpatient stays, improved compliance with medication and treatment plans. These are all things that we want for our patients, and when we're talking about the family, for our loved ones. Specifically looking at two types of mental health conditions. There's evidence for patients with schizophrenia, so a severe mental health condition, that it lessens psychotic and deficit symptoms, and it helps with earlier detections of warning signs of relapse. And then for patients with depression, early intervention with the family when the symptoms are just beginning to emerge can help reduce the severity of the episodes. So I bring this to your attention because that being said, right, patients have concerns, and I think we need to acknowledge that. Um, and families will meet resistance from their loved ones. And we need to be prepared for that. Families need to be prepared for that. Health providers need to be prepared for that. And what are some of the reasons that individuals may not want families involved in their care, right? Think about that for a second before I jump into that. What are some reasons that they may not want? So you're thinking, now I'm going to share. Some of them are straightforward, the obvious, the desire for privacy, right? Patients, loved ones may not want to share their deep, dark, personal, intimate details with their family members. Some may want to protect their family. They don't want to worry or burden their family members. It may be fear of judgment or criticism. They're concerned that the family may be unsupportive or create further stress for them. Concerns about confidentiality. This is related to the privacy. And then the last one, concerns about power imbalance. Um, Fear that the family may take over, right? And dominate decision making, that they will lose control, that they won't be the ones making decisions about their care and treatment and other aspects in their daily life. So these are real concerns that need to be acknowledged and addressed. How can we acknowledge these concerns in the context of also appreciating that we know when we engage families that the health outcomes are so strong? It's really important to use clear, respectful, simple language. So communication, clear communication is critical. We must maintain confidentiality, right? Always protecting patient privacy, but encouraging involvement because of the better outcomes. And, and I'm talking because I know there are a lot of providers in this group, using the clinical encounters as an opportunity for education. So providing psychoeducation on diagnoses, treatments, and opportunities to support and provide education on coping mechanisms, addressing myths and fears and stigma, and linking families to support groups and other resources. I'm not sure how many of you are familiar with shared decision making as an approach, as a concept, but shared decision making is an approach where you include families, patients and families in goal setting and empowering them to support the patient. And families really want to be accepted as partners and remain informed about the decision making and really be given the opportunity to add their expertise. Given all of the concerns that patients and from the family perspective, loved ones may have about the privacy, about the power dynamic, there may be areas of conflict, but it's important, as I said before, to acknowledge that and to clarify roles and responsibilities from the outset. But this approach of shared decision making allows for collaboration and ultimately improves outcomes. Despite what we know about all of the positives around family engagement, we also know that families and caregivers themselves can experience many, many stressors. And that shouldn't come as a surprise, right? If you just pause and you think about the burdens that families can experience, the fact that caregivers themselves would experience stress is not a surprise. What kinds of stresses would you imagine that they would experience? Think about that for a second. There's probably a long list that you have running through your mind. I've put them in several different categories for ease. So there's the emotional and physical stress of caregiving. And that's related to a second category, which is burnout or compassion fatigue. The term burnout, that means one usually experiences that as a result of prolonged stress, and often the caregiver no longer has motivation or interest in their work. They're exhausted. They've reached their limit and just can't do it anymore. Compassion fatigue is a new term that's been introduced where this is caused by prolonged exposure to suffering and the trauma of others, and they just don't experience the compassion and sympathy anymore. No, you no longer have that emotional reserve and compassion to give anymore. And caregivers can experience both at the same time. The third area, what we have been finding with caregivers, one of the big stress is the absence of support services for them. There's no respite care. They need to be on 24 hours a day, 7 days a week. There's no counseling services for them. There's no peer networks for them. And then the last area, what causes significant stress, is this role confusion. Often difficulty in separating the role of caregiver from other family roles, whether it's the role of the wife or the role of the father, the role of the mother. And that can lead to heightened stress. It's challenging to really distinguish between the different responsibilities and expectations of the different roles that the caregiver may have in the family. So the caregiver may be experiencing all of this at once. And no one's asking the caregiver how he or she is feeling. Right? This is an overwhelming experience. How can we support the caregivers? Right? Emotional support. Listen. Validate feelings. Encourage caregivers to form peer groups, find peer groups. Peer groups are wonderful opportunities to come together to support each other. Practical help, logistical help. Offer that respite care. Assist with errands, running to the market, helping with the household chores, helping with the child care. Encouraging self-care, promoting boundaries, taking a rest, like the sleep hygiene so important, finding hobbies, things that interest them, and make them feel valued and give them joy. And then connecting with professional resources if they need counseling for their mental wellness, additional training, or depending on where you are, helplines. I love this phrase, and I use this often with my own patients, some of whom are many of whom are caregivers. You can't pour from an empty cup, right? If you have nothing to give, how can you help others, right? You can't pour from an empty cup. I want to look at a second case study now. And this is a beautiful but heartbreaking piece of work that comes from a master's thesis from Chenjezo Goni, his piece of work from 2019. And it's from a rural village in Malawi. And it's a story of a mother and son, Mbiri and Mabiri. Okay, so I'm going to tell you a second story. So sit back and listen to the second story. And it's a long one too. My apologies. But actually, I'm not sorry. I'm not sorry. This is an important story. So here we are. Let me just move this so I can read my story. Mabiri lives in the outskirts of Chinonde village in rural Malawi. She is an older woman who lives in a very small mud-built hut with her 26-year-old son, Mbiri, who has been living with bipolar disorder for over 10 years. Mambiri is thin and fragile, struggling with hypertension and diabetes diagnosed 2 years ago. Her body is covered with a dirty, worn-out cloth, and her visibly swollen feet are left uncovered. Mambiri's husband of 30 years left her soon after the onset of Mambiri's illness. He was fed up with Mambiri's illness and felt ashamed to have a son with mental illness. My husband left me because of her son's illness, she said. He used to beat both of us. He got so angry and went to stay away, stating that I should seek help from my relatives. Since then, I've been struggling to take care of Mbiri myself. Mbiri is the fourth child born in a family of 7 siblings. He was a bright student and passed through primary education with flying colors. But in the 4th year of his secondary education at the age of 15, he suddenly developed his illness. Since then, Mbiri has visited different traditional healers in the surrounding communities, but his condition has not improved. His last contact with the main hospital was 4 months ago, where he was treated as an outpatient with some medications to be taken daily at home. According to Mbiri, the medications have been helping, as evidenced by his reduced behavioral problems. However, due to a long distance to the hospital, they missed their last 2 appointment dates, which have led to their running out of medications. This has caused Mbiri's behavioral problems to resurface. He is now violent and destructive at times. There is one hospital at the Boma Trading Center that provides mental health services, and it takes almost 4 hours for us to get there on foot. And with the condition of the patient, we take almost the whole day, and that is why he has been on and off medications for the past months, says Mbiri. Because of his illness, Mbiri is unable to complete basic tasks of daily living. He is unable to take care of himself. This means he relies upon his mother for almost everything, such as finding food, washing clothes, and provision of water for bathing, among other things. Because of his illness, he is just like a child. He relies on me for everything, just like a baby, she said. Mbiri's siblings have all since grown and left home to live on their own, far away from the village. With her husband and siblings gone, Mbiri is left to live alone with Mbiri as the sole primary caregiver in this isolated area. Worse still, in this community, as in the surrounding communities, there are no community-based programs to support families who are taking care of relatives living with mental illness, such as Mbiri. I am all alone with the patient. Nobody comes to give me a hand, not even any kind of assistance. I don't have anybody to share the challenges and pain I am going through, she said. Shouldering the responsibility of caring for her son has led Mbiri to give up her 9-year-old business of selling tomatoes. This has left her impoverished, unable to even afford basic needs such as food, soap, and clothes. The harsh demands of being the sole caregiver do not allow her time to work in the field, to grow crops for food, and it is not uncommon for them to go to sleep at night without food. As Mbiri told me, because of his illness, I only spend a little time in the field so that I can have time to find what food to prepare for him and take care of him. So I am unable to do reasonable farming. As such, we don't grow as much food to sustain us. The story of Mbiri and her son is one example of a family caregiving experience in a low-income country such as Malawi. It highlights the effects of severe mental illness on a primary caregiver and shows how caregivers manage their daily lives with an unpredictable trajectory of caregiving. As seen in the story, family caregiving responsibility is highly complex and demands much from the primary family caregiver, including significant sacrifices for the sake of the wellness of the care recipient. It is even more complicated in a setting where no community structures exist to support patients in care and where poverty and stigma are prominent. Nonetheless, families find their own means of managing this responsibility amongst the competing demands of daily life. Ooh, wow. What a story, huh? So this is a hard one. I mean, this is quite an emotional one, but I think this is the reality for many families, and it shines a light on just what caregivers experience. And in resource-limited settings, the demands that are placed on caregivers with very little support. Hmm? So oops, I wanted to pause on that because I think we really need to be paying attention to what families and caregivers need and want, given the evidence we have about how important their engagement is. There was a wonderful study that was done just a few years ago in 2021 that actually asked families and caregivers, what do you want? Imagine that, asking families and caregivers, what do you want? And the findings from that study divided the results into 5 different themes. I've put the source here, so if you're interested, you can go directly to the study. But there were 5 emerging themes, and I've pulled some direct quotations that give you a sense of what families and caregivers are asking for. So the first theme is around just being acknowledged. Mhm. So the direct quote there is, please just have more compassion and understanding for us. The second theme is around engagement and communication, um, which I think is related to the acknowledgement. So listen to me as the caregiver. Don't ignore me. The third theme is around involvement in planning and collaboration in the treatment. Um, and I really like this one quote from the family saying, it's very important for the family to have input. The family sees the patient over the whole day, 7 days per week. Right? The next few themes are really related to this idea of checking in with the family and the caregivers and about their needs, right? This idea of caring for the caregiver. So the quotes reflect that. Check in with me regarding my own health and well-being. Um, the request for ongoing counseling services to support me, um, the need for education and communication, so more psychoeducation for the family and the caregivers, and then linking families and caregivers to other services, whether that is counseling services or other support services. One of the direct quotations specifically referenced financial services. We saw in the beginning, one of the main areas of support families often provide is financial services, but that can also be a big stressor. And then that brings us to our last case study, and then some final messages, and then we'll open it up for questions and discussion. So our last case study is a story about Ama and Kojo. And this story comes from northern Ghana. So Ama is a mother of 4 living in a rural village in northern Ghana. Her youngest son, Kojo, was 3 years old and often quiet, withdrawn, and not speaking much. With little access to early education and no toys or books at home, Kojo spent his days idle. Ama often felt overwhelmed and unsure how best to support his growth. In 2023, Ama joined the local parenting program in her village, which was being implemented by a local NGO with UNICEF support. She was trained as a play leader and began running weekly play sessions for local preschoolers, including Kojo. She also attended monthly parenting workshops focused on positive discipline, hygiene, and early learning strategies. Since the program, Amma has gained confidence in new parenting skills. She's learned how to use everyday items to teach Kojo through play. She's also stopped using shouting or harsh punishment, using praise and patience instead. Amma feels proud to be helping not just her child, but many in the community. Kojo has become more active in social during play sessions. He started speaking more at home and engaging other children. Kojo has shown early signs of counting, color recognition, and storytelling. He is now better prepared to enter formal school. So why have I included this case study? This one's a little bit different than the other one, because I wanted to highlight the roles that families can play in prevention and protection when it comes to mental well-being, right? So positive parenting can help prevent child abuse and neglect. It prevents children's mental and physical health. It protects children's mental and physical health long term. Right? These are two really important aspects. This is about prevention and protection. This is about the future. So according to UNICEF, around 1 billion children ages 2 to 17 face violence each year. 3 in 4 children experience violent discipline regularly. Children with disabilities are at higher risk of abuse, and abuse in childhood is linked to lifelong health problems, physical and mental. Up to 1 in 4 children live with a parent who has a mental health issue. Supporting caregivers strengthens families and reduces risky behavior. So my last slides before we open it up for questions and discussion. Key messages. I'm keeping it simple. 4 key messages. Families should be involved early in treatment. Families should participate in regular check-ins and updates. Think about how culture can influence family engagement, and pay close attention to the needs of caregivers. So if you don't remember anything else from today, because I've talked too much, I've told too many stories, just remember those 4 things and you'll be okay. And then my last slide, these are the resources that I have cited in the presentation today. So if you want to go back and look at any of the evidence that I've used in preparing the presentation, everything is here for you to review. And that is just a big thank you to all of you for inviting me here today and for your attention, and hopefully for your questions and your comments. I want to hear from you now. I'm going to stop sharing and bring us all back together.